My name is Fahad Al-Sharif, and my co-chairman, Dr. Amar Al-Bnayan. And we are very happy to invite our first speaker, Dr. Andrea Visentin. Please come to the stage. And he is going to talk about promising new molecules in CLL. Please, Dr. Andrea, the microphone is yours.
Good morning, everyone. Thank you so much for the kind invitation and the warm introduction. These are my disclosure, and this is the agenda of my talk. We will discuss novel combination in the frontline setting, and we will also talk about novel agent for relapse refractory patient. As we will see later in more details, now we have available more frontline combination for the treatment naive patient with chronic lymphocytic leukemia. But one of the most interested one that will be developed in the next future is this one that uses two second-generation inhibitors, zanubrutinib, a BCL2 inhibitor currently that can be currently used as a continuous treatment. As you can see, zanubrutinib is characterized by the improved pharmacokinetics, and as you can see in this plot, the plasma concentration of the drug is always above the IC50 of the molecule, confirming and sustaining inhibition of the target. And in the relapse refractory setting, in the Alpine trial demonstrated the superiority of zanubrutinib over ibrutinib. Instead, sonrotoclax is a second-generation BCL2 inhibitor that has been specifically designed to improve the selectivity toward BCL2 and to be less active against other BCL2 family members. And in addition, the characteristic of sonrotoclax is that it can inhibit mutated BCL2, the kind of mutation that has been associated with venetoclax resistance. The drug is characterized by a very short half-life of almost 4 hours, so it does not accumulate. In the phase 1 study, the ramp-up phase of the sonrotoclax has been designed as 9 weeks, starting from 1 milligram to 320 milligrams. But the next phase 2 and phase trial will optimize this ramp-up, moving to the classical canonical 5 weeks of ramp-up. The data that I will show you are about the BGB 11-4-17-101 phase 1 clinical trial. That is an international phase 1, phase 1b clinical trials that enrolled patient with either treatment-naive and relapse refractory patient, but also patient with mantle cell lymphoma. This publication that has been presented last year during the ASH Congress focuses on treatment-naive patients, and in particular for those who received the doses of 160 and 320 milligrams. These are the characteristics of the enrolled patient, which are a common patient with treatment-naive CLL. As you can see, the median age is about 62 years. About 9% of the patient have TP53 aberrations. Instead, the rate of patient with mutation, with TP53 mutation, is higher than expected because they use a very sensitive test, being able to identify patient with only 0.1% of mutation, so very sensitive test. After 19 months of a follow-up, the discontinuation rate of zanubrutinib or sonrotoclax were rare. Less than 5% of the patient discontinued treatment due to adverse event, suggesting the tolerability of the two drugs and of the combinations. In particular, as you can see, the rate of grade 1, the grade of grade 3 or higher adverse events are uncommon. And if you look at the number of the bar and the intensity of the bars with dark blue or dark green, you can see that they are very rare. The most common one is, of course, neutropenia, but these severe neutropenia are not associated with an increased risk of severe infection or febrile neutropenia. Moving to some data about the efficacy. After 1 year of the combination, all the patients responding to the treatment with about 40% of complete remission, but the data about undetectable MRD are more interested. In fact, after 1 year of the treatment, 82% of the patient have undetectable MRD in the peripheral blood using the lower doses of the drug, which increased to 91% of the patient taking the full dose of the drugs. Yet, this is not a curve of progression-free survival, but it's just a line. All the patients were alive. The follow-up is short, 19 months, but it is pretty interesting. There has been recorded only one event of PFS about a patient who developed Richter syndrome transformation after 9 months from the starting of the treatment. And the phase 3 Celestial TN trial, which is comparing venetoclax obinutuzumab versus zanubrutinib sonrotoclax, is ongoing, and all the patients have been recruited. So we will see in the next future what will happen. A question is one of the overwhelming questions in the field: are triplets therapy better than doublet therapy? I try to summarize the data about triple therapies in treatment-naive CLL. As you can see, there is always a combination of venetoclax, obinutuzumab, and a BTK inhibitor, mainly a covalent BTK inhibitor. There is a heterogeneity of inclusion and exclusion criteria in this trial because some patients enrolled only young patients, others excluded patients with TP53 abnormalities. Some are MRD guided, others are fixed duration therapies. And in the lower part, I summarize the data about the double combination, either the venetoclax plus a BTK inhibitor or venetoclax plus a venetoclax and obinutuzumab. I try to summarize the data about efficacy and safety. We can see that undetectable MRD rate overall are more common with triplet than double combinations, but neutropenia are more common with triplets rather than double combination. An intermediate level are the combination of venetoclax and obinutuzumab, lower with venetoclax plus a BTK inhibitor, but infection are also more common with triple rather than double combination. Regarding cardiovascular toxicities, we can say that it's not an issue about the number of the drug you use, but the kind of the BTK inhibitor with more cardiovascular toxicities in terms of atrial fibrillation or hypertension if we use ibrutinib rather than second-generation BTK inhibitor. I just add an arrow just to show you that likely the data comes from phase 1 study, while the others are from phase 2 or phase 3 trials. The combination of sonrotoclax plus plus zanubrutinib might be very active, similarly to triple combination, but with the safety profile of a double combination. But again, we need the data from the phase 3 trials. Moving to the relapse refractory setting, there are several number of new agents coming that will come to the clinics. The one that we have available is pirtobrutinib, that is the non-covalent BTK inhibitor based on result of the Bruin 321 trial that demonstrated the efficacy and the safety of these agents in patients who relapse after a covalent BTK inhibitor and even in patients who are double refractory. Another interesting molecule is the fourth generation of rockbrutinib, which is an interesting drug drug because it is able to act as a covalent inhibitor when BTK is not mutated, but it can also it has a mechanism of action as a non-covalent BTK inhibitor when BTK is mutated. We have also the BTK degrader. We have at least 2 inhibitors. The one of Nurix, the other is from the B1 medicine. We have some data about the bispecific antibody also in the field of CLL. And last but not the least, the IRAK4 inhibitor, evamusertib, which is moving to the clinical stage. This drug in combination with BTK inhibitors is able to further decrease the activation of the NF-κB pathway and so to improve the outcome in relapsed refractory patients. BTK degraders are a novel class of agents that act in a different way because they do not inhibit a kinase. Instead, the drug is able to bind the target and the A3 ligase, favoring the ubiquitination of the target, in this case BTK, and the polyubiquitinated BTK is then degraded through the proteasome. The drug is not degraded, but it can be recycled and going to inhibit the new synthesized molecule. The Cadence 1 is an international multicenter phase 1 study. It is a basket trial that enrolled patients with any kind of B-cell malignancies who relapse after a covalent BTK inhibitors. It is, as I said, a phase 1 and a phase 2. There are several cohorts enrolling patients. The most interested one is the one who combine a covalent BTK inhibitor together with a BTK degrader in order to further suppress the signaling led by the BTK inhibitor in B-cell malignancies. Here I show you the updated data from the recent European Congress that has been presented by Lydia Scarfo in relapsed refractory CLL. The study at the data cutoff, 66 patients were enrolled. They were heavily pretreated patients. The median previous line of therapy was 4, ranging from 2 to 10. Very enriched in favorable prognostic markers. Most of the patients relapse after receiving a covalent BTK inhibitor, and as you can see, 63.6% of the patients were double refractory and 18% of the patients were triple refractory. So patients who didn't have any hope for their life. After a median exposure of almost one year, no treatment-related deaths were reported. Only 3 patients discontinued treatment due to adverse event. And with more granularity, you can see that we can say that the treatment is pretty well tolerated. Very few adverse events of grade 3 or higher adverse event. Again, the most common is grade 3 or higher neutropenia, which is of course not an issue for expertise hematology as we are. Very low rate of infection, severe infection and febrile neutropenia. Of interest, this drug can lead to an increase of lipase and amylase. The majority of these patients are asymptomatic and no patient develop pancreatitis. The mechanism is unknown, but it resolved after a few weeks from the start of the treatment. The identified recommended phase 2 dose is the 200 milligram, and you can see that overall the overall response rate is pretty high, 80 to 90%. It is consistent in high risk group of patients, 90% of overall response rate in double exposed patient and 75 in triple refractory patient. This led to a very encouraging progression-free survival with about 77% of the patients still alive and progression-free. The next year we'll start the Cadence 301, the phase 3 Cadence 3 trials, which is now enrolling in the US, but it will be worldwide available next year. The other drug, the other BTK degrader is the ones produced by the Norix. The name is bexobrutideg. The 301 study is another phase 1 basket trials, but which enrolled also a cohort of patients which are BTK naive. Again, all the patients enrolled are heavily pretreated. The safety profile again is good with very few high-grade adverse events. The overall response rate is similar to the competitors, and this kind of degrader is active in patients with or without BTK mutations. Moving to bispecific antibody, you know that we have several bispecific antibody available. They have different targets. Some are targeting CD20, while others are targeting CD19. You know that some of them are given as a fixed duration therapy, while others are given as TL progressions. Some are intravenous, while others are given as subcutaneously. The most advanced and interesting data for me are the ones published in the EPCOR CLL1 trials, which is again another phase 1, phase 2 study, which enrolled relapsed refractory patient with chronic lymphocytic leukemia. And the first part of the study, the so-called expansion study, epcoritamab, a subcutaneous bispecific antibody, was given with 2 step-up doses, but then the trial was amended to include another step of the ramp-up of the epcoritamab. These are the characteristics of the few patients enrolled, again enriched for heavily pretreated patients with unfavorable markers, including some patients who failed also pirtobrutinib. And we can see that the optimization phase, adding another step-up dose with epcoritamab, allowed to decrease the overall rate of cytokine-releasing syndromes recording when the patient received the full dose of 48 milligrams, and also to to decrease the rate of ICANS. And both the reductions of cytokine-releasing syndromes and ICANS are associated with lower levels of serum interleukin-6 in the serum of the patients. The overall response rate is pretty good, 61%, including 39% of complete remission, suggesting that these kind of agents can be used as a bridge for a more definitive treatment, such as allogeneic stem cell transplantation or CAR T cells. You can see about 40% of the patients were able to reach an undetectable MRD, but if we focus on responder patient, the undetectable MRD, including the most deeper one, undetectable MRD 10 to -6, is pretty high, 67%. And the median follow-up in this heavily pretreated patient is about 12.8 months, and the median overall survival is not reached. My last slide is just to show you some data in patients with Richter syndrome transformation. That is a cohort of patients with very, very aggressive disease, and this novel agent showed promising activity also in this heavily treated patient with very aggressive disease. And thank you for the attention.